All right, so speaking of tuberculosis, we're now going to talk about the genus Mycobacterium. We all know that this is like, the quintessential acid-fast organism. So when we hear acid-fast, we think TB. And as we mentioned early on, we know that it's an obligate aerobe. So typically, will settle in the apex of the lungs. Now, as far as the cell wall concentration is concerned, you really don't have to get too detailed into the composition of the cell wall structure for Mycobacterium, but just to understand why, for example, it's acid-fast, if you look that there is a high concentration of lipids with long-chain fatty acids that we call mycolic acids, okay? That gives it its acid-fast property, but it also makes it resistant to drying. Lots of other bacterial agents are going to be sensitive to drying and other chemicals. Now, you might remember not too long ago that dude that had the multi-drug resistant TB that flew all over the country. Even though his doctor said, hey, you got multi-drug resistant TB, you should probably stay at home, he was like, I don't think so. And he flew all over the world. And when they finally caught up with him, they put him in a hospital in Denver. And what did they do? They had all of the air vents with UV light on them. And the reason I'm telling you that is because Mycobacterium, even though it's semi-resistant to drying and some chemicals, it is still susceptible to UV light. So that's one of the ways that we can help prevent the spread of tuberculosis. This image is really just showing you the makeup of the cell wall with the polypeptides and your lipids in that cell wall, okay? And again, not very important, not very clinically relevant, so we're just going to kind of move on from that. Now, the different species we're going to talk about for Mycobacterium, number one is, of course, tuberculosis, okay? And we will follow that up with talking about Mycobacterium leprae, or leprosy. And then we're going to talk about the atypical mycobacteria, okay? So lots of things that we need to talk about for Mycobacterium. As far as tuberculosis, okay, we already know that the auramine-rhodamine stain, remember, is the screening stain, and that's followed by the acid-fast stain as a confirmatory test. One of the types of media that TB can grow on is called Lowenstein-Jensen, okay? So that might be a type of media that you kind of keep in the back of your mind as far as growth for tuberculosis. But you also see here slow growing, all right? So for culture of TB, we're talking 2 to 3 weeks before you're going to see the organisms growing on Lowenstein-Jensen, okay? Now, the reason I say that is because you can get a question where you have somebody with nondescript respiratory symptoms, okay? Here's your vignette. You've got a 65-year-old male. He presents with coughing up bloody sputum, fever, okay? And they cultured the sputum. Organisms grew in 24 hours on McConkey, and he was PPD positive, okay? So you're like looking at that PPD going, man, I really want to answer tuberculosis, okay? But what tells you it's not TB? 2 things I told you tells you that it's not TB. The first thing is that it grew in 24 hours, all right? Anything that grows in 24 hours, not going to be tuberculosis. The second thing I told you was that it grew on McConkey. Remember what we said about McConkey? We said it was selective and differential. TB is not going to grow on McConkey agar, all right? So that was a vignette actually for Klebsiella, okay? But you got to watch out for that. They may throw random PPD in there, and in that distractor list, you're going to see Mycobacterium tuberculosis, but you can't pick it. You really have to read the question, okay? Another caution I'm going to give you as far as if you're given a diagnosis question is they know students always get confused between Mycobacterium and Mycoplasma. So I guarantee you, if you're asked a diagnosis question, in that distractor list of yours, you'll have Mycobacterium and you'll have Mycoplasma. You got to know now not to get those two organisms confused, okay? So I know a lot of students do that, so keep that in mind. Okay, as far as virulence factors, they list some distinguishing features here, okay? Production of niacin and the heat-sensitive catalase. That's not really important for USMLE, so we're going to move on. I'll tell you that the most important virulence factor for tuberculosis is what? Is that it's obligate intracellular, okay? Now, the reservoir for TB is the human lungs, so basically the respiratory tract. Therefore, we're talking transmission by respiratory droplets. One of the ways that is thought is pretty easy to pick up tuberculosis is when there is recirculated air. And one of the places you see that pretty frequently, clearly, is on an airplane, okay? Which is why when a guy was flying all over the country, they had to go back, find out everybody that flew on every flight with him, and they had to go back and test them for tuberculosis because of that recirculated air would make it very easy to get TB. Okay, I said for virulence, it's facultative intracellular, all right? That is its most important virulence factor. Now what you see listed here, the sulfatides, all right, that is what helps it to be facultative intracellular. It helps it inhibit phagolysosomal fusion, all right? But the fact that it's facultative intracellular is still its most important virulence factor. Now, the cord factor is sometimes talked about for TB. One of the things that causes this serpentine-like growth of the organism in vitro, but it also inhibits the migration of white cells, okay, and can disrupt the respiration going on in the mitochondria, okay? But again, I'm going to caution you, if you're asked about the most important virulence factor for TB, it's the fact that it's obligate intracellular. So that may get back to the sulfatides, okay? Now, pathogenesis, this is interesting, okay? If you look at the pathogenesis for TB, and why I'm telling you that it's most important to know about the fact that it's facultative intracellular, you will see in the second bullet point that there's no exotoxins. It's gram-positive, so there's no endotoxin. The damage that's done during tuberculosis is done by the immune system trying to kill it, okay? And I'm going to talk about that. I've already mentioned, remember we said TB is going to get into macrophage. It's going to inhibit phagolysosomal fusion. It's going to escape and start replicating within the macrophage, okay? And the response the macrophage is going to have for that is that granulomatous formation, okay? The granulomatous formation is also described as your delayed type hypersensitivity reaction, okay? So if they gave you a case of tuberculosis and asked you what kind of hypersensitivity it was, you would have to go with a type 4 hypersensitivity, one that was T-cell mediated. Okay. Now, diseases. What are we talking about with tuberculosis? We've got several different outcomes here, okay, for TB. Let's say I was sitting on a plane with Mr. Dude that flew all over the world with his drug-resistant TB. All right, maybe I was sitting right next to him, okay? And I inhaled quite a good dose of his tuberculosis, all right, his organisms. He was coughing, I was inhaling, because you got to breathe even on an airplane. And there's one of a few things that can happen, all right? I'm going to inhale the organisms. They're going to get taken up by my alveolar macrophages. And the macrophages, again, they're going to try to kill them, all right? So in trying to kill them, they're going to leave the lungs and they're going to go to that draining lymph node to start to present that antigen to T cells. Now, what's going to happen is now we're getting really a full-blown cell-mediated response, delayed type hypersensitivity response, all right? And we start seeing that granuloma formation. When you initially see that granuloma formation in the alveoli, where the macrophages originally took up the organisms, we call that a focus because it's one, okay? But now the macrophage is traveling to the draining lymph node, presenting antigens, to the T cells, and again, now we have granuloma formation there. Now we have this complex of granulomas that we call a Gone complex, okay? So now I've been exposed to TB, my organisms have taken it up, and now, if I'm relatively healthy, my macrophages are going to keep them sealed up in a nice granuloma. Will I be hacking up blood, coughing, having trouble breathing at that point? Maybe not, okay? I've been exposed to TB. My immune system's fairly good. I'm carrying TB. I could easily spread TB, but I'm not showing too many visible signs that I have tuberculosis, okay? How are you going to know I have TB? Okay, in that instance, all right, we're going to do a PPD skin test. That's how we screen large numbers of individuals for exposure to TB, okay? So now I get my PPD skin test, whether it's the single test, which is now often replaced by that two-step PPD, and they're like, whoa, you're positive. And I'll be like, come on, I don't work in a hospital. I can't have been exposed to TB. And they say, well, you know what, we're going to do a chest x-ray anyways. They do a chest x-ray, they identify the Gone complex, and then I have to go get treatment, all right? So that's one scenario. All right, here's another scenario. It doesn't happen as often, but I'm sitting next to the dude on the plane, he's coughing on me, I'm breathing. But let's say I have really good immunity, okay? The one outcome that can actually happen is your immune system can actually clear that infection, okay? It's not as common, but that can happen. So that's one outcome. The outcome we talked about before was we're setting it up in the granulomas. And then the third outcome you're very familiar with, I can say you have a patient present with fever, night sweats, weight loss, bloody sputum. In that case, we have really an active case of TB, where they're not sealed off necessarily in the granulomas. Could be someone that's immune compromised, for example, but you all know that that's the classic vignette for tuberculosis. Okay? Now, let's go back, though, to that first example I gave you. You have these organisms, they're sealed up in granulomas, and now I'm walking around New York City spreading my TB. Okay? I'm positive. All right? Spreading my TB to everybody, and now I get sick. All right? I'm in New York, I'm run down, God knows what I've come in contact with, and now I get sick. So my immune system is working overtime. It takes a lot of energy from the immune system to keep those granulomas formed. Imagine you have to have the activation of all the macrophages and T cells, constant activation, to maintain those organisms within the granuloma. Okay? Now I get sick. All right? I'm a little bit immunocompromised. What happens? I can't maintain those granulomas anymore. And what happens is they begin to erode, and there's viable tuberculosis in the granules. They will get out and they disseminate. And they can go at that point, because I'm run down, anywhere they want to go. We call that reactivational TB. Okay? So reactivational tuberculosis, we've got erosion of the granulomas. It can go anywhere. I can also maintain those granulomas for long periods of time, and once I get older and my immune system naturally starts to decline, I can get erosion of those granulomas and reactivational TB. Once that happens, you can find TB in almost every bodily fluid and body site. And we call that miliary tuberculosis. And miliary actually comes from the word millet, which means to seed. So what we're doing is we're seeding all of these different organs with tuberculosis. It can even go in the spine, can go to the CNS, it could go basically at that point anywhere it wants to go. All right. So TB is a little bit of a complicated disease. Okay. Diagnosis, we know we can do, if I give you that vignette of coughing up bloody sputum, fever, night sweats, we do an acid-fast stain of the sputum. Okay. That's going to be one of the confirmatory tests for diagnosis. But let's say we're in a large city, they get suspected TB all the time. They're going to do the screening test, again, which is the auramine-rhodamine test. If there is an acid-fast organism in there, it's going to stain that bright fluorescent green, and then we're going to confirm it with the acid-fast test. Okay? So that's one part of the diagnosis. Now, the second part is the PPD. So we had a situation where I'm walking around, I got my TB, but I'm really not feeling all that sick. Might have a low-grade fever or something like that. How are we going to know that I have TB? Well, it's really important if I'm in healthcare and I'm going to be coming in contact with other patients. So you know, as healthcare providers, you have to get the PPD at least once, sometimes some require it twice a year. Okay? That's going to tell you if you've been exposed to tuberculosis. Okay? So the PPD skin test, all right, stands for purified protein derivative. They inject a little bit of this tuberculin protein subcutaneously, and if you've been exposed to TB, your immune system, having a good memory response, remembers that and will go and attack that tuberculin protein. And if you're positive, and I'm going to show you the most obvious down at the bottom, you're going to react with that delayed type hypersensitivity reaction. Okay, now, there are different measurements of the PPD. So for example, I'm in a low-risk population. So I can actually have a pretty whomping reaction to PPD before I have to go get chest x-rays, etc. All right? You now, because of your chosen profession, are in a high-risk population. So you're out there with the homeless, the drug users, you'll put medical students in there, and you have to have 10 millimeters or less of induration to be considered positive. Okay? Now, in a patient with AIDS, or one that's HIV positive, just about any reaction at all is going to be considered positive. Okay? And that is because the virus in HIV destroys the very cell type that gives you the PPD. Okay? So the further you are in progression of AIDS, the less you're going to be able to respond to the PPD. Okay? Now, let's say I'm PPD positive. I go get a chest x-ray and I'm negative. What does that mean? That means that at some point I was exposed to TB, don't have an active case of tuberculosis. I could have been vaccinated for TB. Everywhere in the world besides the U.S., they vaccinate for TB. So you get somebody that was vaccinated for tuberculosis, you give them a PPD, you know what? They're going to have a really nasty reaction. All right? So the thing to remember is just because you're PPD positive does not mean you have active tuberculosis. Okay? It just indicates exposure, and you have to do additional tests to confirm the TB. So, diagnosis, the positive skin test indicates exposure, not necessarily active disease. You can grow it, all right, but remember it's slow. So any indication you think somebody has TB, but the cultures come back in 24 hours, it's not TB, okay? And we really don't use serodiagnosis very much. All right. The fact that they produce niacin and they're catalase negative, they're probably not going to use in the vignette. Okay? Now, that brings us to treatment. Now, treatment for tuberculosis is a virtual nightmare. All right? It is a multiple drug regimen that goes on forever. So compliance is a huge issue with treatment for TB. Okay? Now, for TB that is in somebody that's got TB, they're in an area that there's not a lot of drug resistance associated, they're going to get the first 2 months a combination of isoniazid, rifampin, and pyrazinamide. Okay? Then, for the next 4 months, it's just going to be the isoniazid and rifampin. Okay? Now, in areas where there are significant cases of drug-resistant TB, you're going to add drugs to control for drug resistance. So ethambutol and streptomycin, if you've got somebody, in a vignette, let's say from New York City, okay, where they do have a higher incidence of drug-resistant TB, you're going to probably have to throw those additional drugs into that cocktail, all right? So that's something you need to think of. So for prevention of tuberculosis, let's go back to the scenario where I sat next to the guy on the plane, I got tuberculosis, got a good, healthy immune system, okay? So I don't necessarily realize that I'm sick. I go get a PPD because I want to work at my kid's school and do some volunteer work, and lo and behold, it comes out positive. So now my physician orders a chest x-ray, and whoa, lo and behold, it comes out positive. Now what am I going to do? Now I'm going to take isoniazid for 6 to 9 months, all right? And that will prevent it from going to active tuberculosis, okay? Now, what's important to be aware of is that there is a vaccine. What's also important is that we don't use it in the United States, all right? Since this is the United States licensing exam, okay, we're looking at things that go on in the U.S. So even though a lot of you probably had the BCG vaccine, know that we don't use it in the U.S., okay? So that's going to be an important point. And as I mentioned before, UV lights and also HEPA filters can be used to treat that contaminated air. So in somebody with tuberculosis, where they isolate them in a hospital room, again, they have those UV lights on all the air filters, okay? And all of the air that's kind of going into and out of that room. So that's going to be also important for prevention of TB. Now, we've talked about TB. Now we're going to talk about what are called the MOTS group, the mycobacteria other than tuberculosis. Now, these are atypical mycobacteria. They're not typically considered contagious, all right? And we see a lot of these, as you already know, in immune-compromised patients. Can look very similar to tuberculosis, especially when we're talking about Mycobacterium avium intracellulare, for example. So as far as the distinguishing features for the MOTS, you really don't need to worry about the production of the pigments and the photo and scotochromogens. They're not going to ask you about that, okay? On step 1, it's probably going to be more where they give you the vignette, you have an AIDS patient, they may or may not give you their T cell count, and then they're going to want you to probably make a diagnosis, okay? So let's look at some of these organisms. Now, Mycobacterium avium intracellulare, or MAC, okay? And then we have Mycobacterium kansasi. These can look very similar to tuberculosis in somebody with AIDS. So you get the fever, the night sweats, the coughing up of the bloody sputum, all right? Now, in MAC and in Mycobacterium kansasi, you're typically going to have a pretty low T cell count, all right? So generally less than 50. Whereas an AIDS patient can get TB with a T cell count of above 200, okay? So TB, if the T cell count is relatively high, if the T cell count is low, generally below 50, then you're going to go with one of the atypical mycobacteria, okay? So we see respiratory infections. We can also see gastrointestinal infections, and because, again, we're dealing with the immune-compromised, disseminated infections. Some of the other atypical mycobacteria, not something we're going to talk about in AIDS patients. We have Mycobacterium scrofulaceum and Mycobacterium marinum, all right? Now, marinum is one of my favorites. It does show up on the USMLE every now and then. What's funny to me about Mycobacterium marinum is almost always in the vignette. They're going to say that there was some exposure to fish, okay? And here you'll see under clinical presentation, cutaneous granulomas, again, we're still in mycobacteria, in tropical fish enthusiasts. What is that? What is a tropical fish enthusiast? Now, I think fish are nice. I like to look at them, but do I jump all around and be like, my fish, I'm so... No, that's a tropical fish enthusiast. They're going to get Mycobacterium marinum. How are they going to get it? They're cleaning their fish tank. They get a little cut in the skin from some coral or something that they have in there, introduces the organism into the skin. Now they get a cutaneous granuloma on the skin from Mycobacterium marinum. Okay? How are you going to treat it? Isoniazid, rifampin, or ethambutol for treatment of Mycobacterium marinum. Now, lymphadenitis, okay, for scrofulation is actually fairly common disease of children where you get these enlarged cervical lymph nodes in children. And that will typically require surgery as far as treatment is concerned. So we've got MAC, we have Mycobacterium kansasi for AIDS patients, very similar to TB. We've got these atypical mycobacteria that are actually fairly low yield for step 1, but occasionally they do show up, okay? You know, we always give you the high-yield organisms, but they're always going to throw some random ones on there that people aren't as familiar with. With Mycobacterium marinum, that presentation is fairly simple, and in the vignette, they will usually tell you about the association with fish. All right, so you don't want to miss that one. Let's move on to Mycobacterium leprae. Leprosy is the disease used to be called, or now Hansen's disease, is caused by Mycobacterium leprae. Again, acid-fast bacilli, and in this case, you're not going to be looking at sputum necessarily, but of the lesions in which you do a punch biopsy to find the acid-fast organisms. And these are actually not facultative intracellulars, but they're obligate intracellular pathogens, all right? So it's a little bit different than what we talked about with TB. They also like a little bit cooler temperature, and that's going to help you in knowing kind of the sites at which leprosy tends to grow. The reservoirs are the mucosa, the skin and nerves. And do we see much of this in the United States? No, we don't. So all in all, this is probably fairly low yield. I love the second bullet point there, but there are some infected armadillos in Texas and Louisiana. So if you're living there and you see an armadillo, you better run, okay? Now, transmission is from the nasal discharge from patients, okay? And as far as pathogenesis, the pathogenesis depends on the patient's immune system. If you have good cell-mediated immunity, you're going to get tuberculoid leprosy, which is much less severe. If you have a poor cell-mediated immune system, you're going to get lepromatous leprosy, which is much more severe. So let's look at the different forms of leprosy, okay? Tuberculoid leprosy, we have a strong cell-mediated immune system. We do have an analogous test here to the PPD called the Lepperman skin test, but it's only positive in tuberculoid leprosy, okay? If it's similar to PPD, we're relying on our cell-mediated immune response, all right, to give us that positive reaction. In lepromatous leprosy, we don't have good CMI, so we can't react positive to that Lepperman skin test. Now, with a good cell-mediated immunity, you've got very few organisms in the tissue, but the damage here is done by the overwhelming immune response to the organism. You're going to get what? You're going to get granulomas, okay? You're going to get enlargement and damage of the nerves. This will predispose you to burns and trauma because you get loss of sensation from that nerve damage. And as far as the lesions go for tuberculoid leprosy, you have a few lesions that are macular lesions, okay? Now, if you were to palpate within one of those macular lesions on a patient, they may have lost feeling, okay, because of the nerve damage there. And for diagnosis, what you're going to do for that is you're going to do that punch biopsy and then follow that up with an acid-fast stain. Lepromatous leprosy is the other form of leprosy where the patient has gone into this with a weak cell-mediated immune response. So you may try to do the Leperman skin test, but it's going to be negative regardless of whether the patient is positive for leprosy or not. In the case where you have no cell-mediated immunity, the organisms can grow completely unchecked. So it's total uncontrolled growth of bacteria with no immune system to keep everything under control. So similarly, you have nerve damage, all right? You have loss of sensation. You're also very susceptible to burns and trauma, but it's not because you have granulomas maybe pressing on the nerve or you have nerve damage. It's because the organisms have damaged the nerves. Now, as far as the lesions, here's where you have a big difference, okay? Tuberculoid leprosy, you have a few macular lesions. Lepromatous leprosy, you have multiple lesions, and they're nodular. And eventually, if the disease progresses long enough, you're going to start to get reconstruction of the face. You're going to lose the eyebrows, the nasal septum, and then that's described as a leonine face or a lion-like face, which some of the patients get with this extreme form of leprosy. So those are the two extremes. I'm going to explain more when we talk in the immunology videos about the immune system and kind of how those two different forms of leprosy arise. Okay? Now, diagnosis in the lesions, whether we're macular lesions or nodular lesions, we're going to do a punch biopsy. We're going to follow that up with an acid-fast stain. We're going to be acid-fast positive. All right? Can we culture it? No. Remember, these are obligate intracellular pathogens. All right? So we're not going to be able to culture it. So we do the biopsy. We're acid-fast positive. Again, we've got multiple drug therapy here. In this case, we're going to use dapsone and rifampin. And in the case where we have lepromatous leprosy, we have to add a third drug, clofazimine. All right? In the case where leprosy, especially in developing countries where leprosy is endemic, you would like to give dapsone to family members in order to prevent acquiring the disease. Okay? So that speaks to the treatment and prevention.